Hi, everybody. Good afternoon, and welcome to this webinar on optimizing MSK diagnosis and treatment through diagnostic ultrasound, a case study approach. So today I'm delighted to be joined by Shane Bryan, a advanced practice physiotherapist and MSK sonographer from Motherwell Physio based up in Scotland. So we asked Shane to share his experience with us today. He's been using the Alpinian diagnostic ultrasound for a while for MSK scanning and ultrasound guided injections in his clinic. So there at Motherwell Physio is providing a successful service and providing optimal care to patients. So we're really looking forward to hearing just about the cases he's generally seeing day to day. So Shane will go through a short presentation and then followed by a Q&A. So we'll cover some of the pre-submitted questions we've received. But as always, if you are listening live, please pop some questions in the Q&A and we can get to answer those as well. So with that, I'm going to hand over to Shane and then we can answer some questions afterwards.
Okay, so just before I start, my camera is down here, but my screen is up here just in case you're wondering why I'm always looking up. All right, guys. So yeah, I've been asked by PhysiQuick just to give a quick go through on cases that I've seen in clinics, just so it's a bit more real life rather than getting a salesperson to try and sell you this kind of stuff. So, just to run through things, yeah, so I have been now qualified as an MSK sonographer for 2 to 3 years, I think. Been an injection therapist for 4 or 5 years. We use ultrasound every day in our clinic and you do ultrasound guided injections. It's a big part of our kind of USP for what we offer here, as there's not many clinics up around Scotland that do. So we'll get started on case studies. So nice and easy. So first case study here is, Katie, can everyone see that all right? Is that fine? Yeah, perfect. So case study number one. This was a male, as you can see, late 30s that turned up into clinic. As you can see here, he fell, landed on his right side. And when I say on his right side, he landed on kind of his right hip, leg area, kind of after getting nailed in a tackle while playing a game. He was able to continue playing, didn't really actually have much pain at the time, but as you can see there, woke up the next day with a huge amount of swelling in kind of this outside of his thigh, the distal third, and also the outside of his knee. Since then, the swelling kind of never went away, but he kept trying to play on it. So every time he go back to train or football, the swelling would balloon back up again. Still able to play, but it just was starting to get worried because he's like, well, why the hell is this swelling up? Especially when there's no pain, he started to worry about all sorts of things. He did try and take a week or two off football, but felt like it made no difference. So we presented them into clinic around 4 weeks after the initial injury. After testing him, his hip was fine, knee was fine, strength was absolutely fine. And so there was massive, and with the amount of swelling, as you'll see in a minute with the pictures, we suspected a more Moral level lesion, which is basically like a degloving injury of the subcutaneous tissue on top of the muscle area. So again, to confirm this, this is where the ultrasound came in handy. So I'll just click through to our Instagram because we shared this up here. Again, Katie, is that coming through all right for everyone? Yeah. So you can see here, this is a video of the swelling. You might have to ignore my terrible camera work. As you can see there, when we push through, it just balloons up, right? Now, whether you know, some of you may have heard of Moral level lesion, but basically this is what it is. You've obviously got that kind of degloving where the tissue basically gets sheared and it causes a hematoma to develop in between the fascial layers. And it's quite a tricky injury to deal with because it doesn't go away easy. So as you can see here, that's his good side, that's his bad side. And again, one of the things that led us towards this conclusion was the fact that he doesn't actually get that much pain. So here you can see this was actually one of the procedures we carried out, an ultrasound guided aspiration of it. As you can see on the screen here, that big black pit is the actual fluid collection in between the quadriceps, the vastus lateralis, and the subcutaneous tissue above. And as you can see here, this is just drain, 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 and we actually ended up taking off about 54 mils, if I remember correctly, off his first time. Now, this is where the ultrasound came in handy because it confirmed that that was the diagnosis and it wasn't anything else, so I didn't have to send him on anywhere. I was then able to carry out an aspiration immediately, which is kind of how these are tend to be treated, because the idea is that we want to remove the fluid in between the layers to allow the layers to sit closer together, followed by compression, so allows better scar tissue formation. Now, this man, like as any that deal with footballers will realise, he listened to the advice for about 3 days, felt loads better, was going up, swelling's going way down, and then went back to training. So it re-swelled up again, and he ended up coming back in 2 or 3 times within a few weeks to get it redrained. Each time there was less and less on it. And once we got down to where there was only a small amount, we just left it at that. Again, that's where the ultrasound came in just to confirm, right? Yeah, there's not a huge amount on that. It's looking like it's scarring great. So we just left it at that, and he is now back playing, no swelling, and healed up great. Perfect. That's the first one. Now, second case study. So this was a male, again, late 20s, playing football, felt a pop in his calf. As most of you will probably gather, straight off the bat, this is what some people refer to as a tennis leg or medial gastro head injury. As you can see there, he was unable to continue to play, came in 3 days post-injury, again, unable to single leg heel raise due to pain on palpation medial gastric head. Weak, again, ultrasound is not going to need to tell you that they tore his medial gastric head. However, where ultrasound comes in handy for these, especially if you're working more higher end athletes or that, is helping to grade it, which can help you distinguish return to play times. So again, here we can see just a quick snippet of this. As you can see here on the normal side, we can see that's where what our calf muscle should look like under ultrasound. Now, this is a longitudinal view here, where we've got the part where the Achilles comes up from this direction. This is your soleus underneath here. Then it becomes the free gastric aponeurosis, and then this aponeurosis kind of comes diving down here, and it opens up into the gastric head here. As we can see over here, this is the same image on the bad side where he's torn it. So he's torn through the free gastric aponeurosis. And actually, surprisingly enough, his the muscle fibers look quite intact here. So it's more of just an aponeurosis injury. And I haven't got it up here, which I should have thought of this, is the classification system we tend to use with ultrasound is the Pedri classification, where he grades it 1, 2A, 2B, 3, I can't remember, it's 3A, B, and C as well, and 4. And depending on the grading of it, it can give you the idea of kind of return to timeframes, because tearing through just the aponeurosis is different timeframes to tearing through the muscle fibers and the aponeurosis, which is again different to if it's just a fiber tear. Again, just looking below here, this is the same calf muscle, but in a cross-sectional view. So again, normal, we can see quite a nice architecture of the muscle, whereas also here we can see tear with this nice black pit where we have a lot of hematoma and fluid already started to develop. Okay, so again, this just gave us an idea of grading system, so we could kind of go, right, your return to play score, this is when you're best to return to play, because as we find with a lot of these are the ones where, especially when it's gone for the aponeurosis, these are the ones that recover really quickly but keep breaking down. So using ultrasound to kind of clarify he falls into this category means that we can then turn to him and go, right, you're going to feel better by X. However, you still need another week or two of building up on this, because if we return that bit soon, it's going to go again, and you're going to be back in here 3 or 4 times over the next few weeks. So he followed the advice, and he was back playing six weeks with no reoccurrence since. So that was quite good. Although he was pain-free in his case within 2 weeks. But again, knowing where the tear was, we were able to hold him back a bit more. Now, next one, male mid-40s, self-employed joiner, keen gym goer. Yeah, as you can see, lifts weights multiple times a week. He's been to see loads of different people, diagnosed with tennis elbow by everyone, seen local physio in Edinburgh, had conservative treatment along with shockwave. And I say for 6 months, wasn't shockwave for 6 months, but had conservative treatment, added shockwave to us as part of it with no improvement. Pain overall have been there for a year. Again, as you'll know, we're working with these guys, the tradies. They're not too keen to come and see people straight away, just kind of it'll go away. Again, objectively, Mills, Mosey, Cozan, all positive, pain and palpation of that kind of common extensor tendon just distal to the lateral epicondyle. He got to the point where he's like, look, I'm coming for an injection. Let's get it done, because I'm in agony, I'm struggling to work, etc. And I was like, well, look, you've tried everything conservative, it's not working. let's do that. But as part of our injection procedure, because we do them under ultrasound, we carry out a scan, and then this is what we ended up finding. It wasn't a simple tennis elbow, as you can see here from the video. He's got a nice full thickness tear right through the tendon. It's a partial width tear, as you can see here from the picture below. That's what we would expect to see. You've got your radial head here, you've got your lateral epicondyle here, and then you've got the fibers of your common extensor tendon coming through here in a longitudinal view and attaching directly onto the humerus here. But as you can see here, this nice black fit, as you can see, it extends right from the joint and goes right up, right through the belly of the tendon. It's not, it was kind of partly oblique, which is why it's hard to get a full view right through. Now, obviously, seeing this, putting the steroid in amongst a full thickness tear, not a good idea. So this is where we said to him, look, no chance of doing that, because if anything, this will make it worse. Explained to him what this meant, gave him his options, and we opted actually for hyaluronic acid. We gave him the option of PRP. He just didn't want to bother trying down that route because I think at the minute, again, now physios can't do it. I think at the minute up here, he was getting, there's places that quote about 2 or 3 grand for PRP injections. So he was a bit more kind of like, let's avoid that, but I want to try something. So we opted for hyaluronic acid, Ostenil Plus, and actually in 4 weeks' time, he had complete resolution of his pain. So we got his pain down and advised him on gradually building this up with the understanding that this tear will probably not fully heal and that it's about kind of managing it and working with it. So adapted his whole gym program and that. However, this is where again the ultrasound came in handy because again I've seen these in the past before I've done ultrasound where it presents like tennis elbow, looks like tennis elbow, doesn't look, you would never suspect a tear like this considering the power that he was able to produce. But again, he was a big lad, which kind of why it was hidden so well and why he was able to kind of batter through it for so long. But that's where again the ultrasound came in because if I had to stick a cortisone in that and then he goes out and he feels a ping, he then comes back to me and I'm suddenly then hit for that being blamed because oh the steroid has caused that, which it probably would have exasperated it and yes and made it worse. But again, that's where the ultrasound potentially saved my bacon with that. So, moving on to the next, the female in her 70s. This was an interesting case. She started getting pain in her foot 3 months ago, went on a cruise, nothing major. She said, though, at the start of the cruise, it was just a bit achy. And then, not over the coming weeks, it was just sore and sore. And then, but she said, more or less from the get go, once it started to get sore, that she was struggling to walk. And she said, I was struggling to lift my foot up properly after she said then around 6 7 weeks in all of a sudden the pain just stopped. However, she was still struggling to walk and she still noticed the weakness in her foot, so she was kind of describing like a partial foot drop or a slapping foot where she was walking, she felt it was kind of going like that and she had to turn her foot out to walk because it kept kind of dragging a bit. Reported tripping over her feet multiple times and having to use a stick because she felt there was no power in her foot. And then one day she looked down and she noticed there was a massive lump in her foot, which she said has been getting bigger, in particular within the space of 2 weeks. And then all of a sudden it didn't stop growing. And then for about 4 weeks, it hadn't changed. Still getting no pain, but the weakness was still prevalent. So this lump had grown, stopped growing, stayed there, never reduced, but never produced any pain, but still weak. Obviously, objectively, there was quite a noticeable lump and just anterior to her talocrural joint, quite a noticeable reduction in dorsiflexion, but all of her movements were absolutely fine. Big toe extension was fine. On palpation, the lump felt hard and non-movable, which obviously as a clinician made me shit myself for obvious reasons, panicking, thinking, oh God, I hope to God this is not something nasty. So said to her, look, we don't do lumps and bumps, that's technically out of our remit, but again, feeling a bit going 70 years old, at least I'm able to tell, is this a lump that we should be worried about? Can we rule out and just say it's something else? I was hoping that was just going to be enough osteophyte, but turns out this lady had completely snapped her tibialis anterior tendon. And as you can see here from the top of the screen, there's the anterior talocrural joint there, or ankle joint. And then just here you can see quite nicely in this image, the fibers of the tibialis anterior. The nice the black lines around it kind of really differentiating the tendon from the surrounding structures and the fibers in between. Then you look down here and the tendon has completely snapped and retracted, which is why we've got quite a big lump at the front of our foot. So then immediately I was able to tell her, look, this is great. And this would make sense with our presentation, with the fact that it started off painful, started off getting weak, and then all of a sudden the pain disappeared, and then a lump started to appear because the tendon had obviously snapped, which was no longer producing pain. And but had been left with the weakness because obviously the tendon wasn't there to do its job. Again, so I was able to tell her this is what the lump is, these are your options. For obvious reasons, her being 70 with other health conditions, she was like going, I would never ever think about surgery. So I referred her on to orthotics to consider some kind of splinting just to help her move around because as we explained to her, obviously, as you know, we don't want her at her age tripping over and falling because that can create a whole bigger set of issues. Again, ultrasound came in quite handy here for obvious reasons because otherwise waiting times in the NHS for an urgent ultrasound scan around these areas is about 6 to 12 weeks. And obviously when people are coming in worried about lumps and bumps, you'd ideally want to reduce that kind of worry if you can. Last one of the case studies I have here, male 40s, big gym goer. I don't know why I've written the date on that, but anyway, that was February this year. Came in with right shoulder pain and he's been having it on and off for about 3 years. I think on and off, he says for the last 3 years, it's never gone away, but it goes up and down. Notices pains and weakness when trying to do shoulder press, lateral raises, bicep curls in the gym. Seen 3 different physios, all said he's got rotator cuff tendinopathy. Rehab can't follow it. Everything he said, they've given him all the right stuff. They've all tried a bit of hands-on stuff to try and just desensitize, made no improvements. Came in as the pain has just been gradually getting worse, especially over the last year. He says, and the pain is now more or less there every day. And then a friend recommended us, so we just wanted another opinion. Again, testing full range of movement, passively and actively. Resistance was typically fitting the bill of a really grumbly rotator cuff tendinopathy. Obviously, with the history, I had questioned if there was a bit more of a partial tendon or even a slap lesion underlying, which is then why maybe he's getting a secondary tendinopathy. And then we carried out the scan. And interestingly enough, as you can see here, on the right side of the screen, here is his supraspinatus tendon in long view. So you've got this, what we call the kind of carrot beak, because supposedly it looks like that, but I'll let you decide if that is. We can see the tendon, this is it here, the top of the tendon here, and the bottom of the tendon here. So you've got this nice bulk here. And then you've got this here, where the tendon is completely absent. So he had had a full thickness, complete tear of his supraspinatus, which is quite surprising considering, again, his full range of movement, along with actually his strength wasn't overly too bad. It was weak, but not what I would expect with that. Again, however, big gym goer, muscly fella, so obviously everything else had managed to compensate around it. So obviously we spoke about this and says, right, as you can see there from below with the ultrasound report, this is just a few bits I took out of my report. He also had he had a long head of biceps tendon tear, not a full thickness partial tear. He had also what looked like a historical tear of the subscapularis with calcific tendinosis. That calcific tendinosis presents a bit differently to calcific tendinitis, which we would expect with a big calcium deposit. This is more along the lines of ones that you see develop more subtle, more speckles within tendons that have had usual injuries before. And also he had an infraspinatus tear, but due to the thickness of his fascial planes on his deltoid, it was actually quite difficult to visualize how to grade the tear and kind of how big it was. But it wasn't big enough to be a full thickness complete with tear, such as this, where the whole supraspinatus had gone. So again, as you can see here, this again was taken off one of our Instagram stories. We spoke to him about his options and that and said, look, you can try rehabbing this to your heart's content, but you're going to be left with restrictions no matter what. This is the reason why you always struggle with certain movements. And he was happy then knowing that information to kind of actually just crack on with things, but also did want to speak to a surgeon about our opinion. So I've referred him on, and enough for people to decide and speak to him about pros and cons and whether that's appropriate or not. So yeah, there's an example of a few cases. And again, with your man there as the last one, again, without the ultrasound, I would have probably fallen to the boat of the other guys. I probably would have referred, just due to the time frames, I would have referred him on for a scan. But again, being able to have it in clinic, was able to go, right, there you go, you definitely have this. So then you can write a letter refer you straight to orthopedic so you don't have to waste time. Again, because again, where we are, the pro pathway is 6 to 9 months to physio in the NHS because GPs will not opt to refer without any invest unless they have images to confirm there's a problem. So it's referred for 6 to 9 months for physio, then about 6 months ways to orthopedics, then another few months to get an MRI, then back to orthopedics. So by even simply having this information means that he can get referred straight to orthopedics from the GP, which saves him again a lot of hassle. And that is all my case studies for now.
Excellent. Thank you so much, Shane. So interesting. I think they've been keeping you busy, haven't they, by the sounds of it?
Nonsense.
Okay, great. Thank you. So if you have any questions about those particular cases and if you're on live, then do pop them into the Q&A. Just got a couple that's popped up here from Steve. Hi, Steve. So on case study 3, Shane, he's just asked about the Ostenil Plus.
Yep.
So did you put full 2 mil into this? And also, how did you do it and what was the location?
Yeah, so I'll put a full 2 mil into it. And the reason we opted for, we went for hyaluronic acid as part of it is because it's a full thickness tear. Obviously, the joint is also exposed. And I went for the 2 mil for that. I went full 2 mil for that reason, because inevitably, with a tear like that, the solution is always going to leak into the joint. And on testing, which I failed to mention, and obviously that part, he did have a bit of kind of joint irritation as well, which would make sense considering the tendon above is not really doing its job. So, from ultrasound wise, we went longitudinal. So, in fact, maybe if I get the picture, it's probably easier to kind of show through. So, from a injection point of view, I don't know, can you see where the hand is on the screen?
Yeah.
Yeah. So, from an injection point of view, I just went straight down and actually dumped the osteoplot partly on top of the tendon here, and then also went a bit into the tendon here in this case, because as I said, I knew part of it would then leak into the joint as well. Okay? So I went about half a mil just above the tendon and the other 1.5 inside the tendon as well, into that area there.
Okay, great. Thank you. So yeah, if you've got any other questions, guys, then you can pop them on there and we can revisit any of the cases that Shane's spoken to. Otherwise, I'll get going with some of the pre-submitted questions. So we had quite a few questions generally just asking about, I guess, sort of like training support for diagnostic ultrasound, journey of education pathways, getting into it. So can try and piece together a few of them questions. But first of all, Shane, that's sort of your experience of what was your background and learning and getting into diagnostic ultrasound to begin with.
So I had done injections beforehand for a few years, and then the place I worked in at the time, we spoke about the guy that owned the clinic at the time. We spoke about how do we branch out, and we ended up going down the ultrasound injection route. So I actually did a course in ultrasound guided injections there, and it was then that I was like going, I can't be injecting people under ultrasound if I don't really know half the stuff I'm looking at in the first place. So that then got put on hold after that kind of 1 day course, to kind of go right, actually continue injecting landmark guided or blind at the minute, and then look at going down ultrasound training. So I did mine with Smoke. Um, s- I can't remember what that stands for again. Sports Medicine Ultrasound Group, which is led by Chris Myers and Rob. I forget his second name.
Rob Louse, yeah.
Yes, Rob Louse. Yeah, so I did mine with them. It's a year-long course. I yes, I had my mentor. So I actually ended up partway through starting the training. I actually didn't change clinics, and I ended up working in a clinic in Falkirk, where one of the other guys there had already trained up in ultrasound and that. So he ended up becoming my mentor. So I did my 250 scans there, and finished off my training after a year, and then I've been doing ultrasound since. And then once I finished off that training, then went back into doing my injections back under ultrasound. Then just because I didn't feel right doing them without being confident in what I was looking at first. So that was how I did it. With regards to training and that, the training is very intense. It is quite hard. If I would say, all in all, if you're looking at this from someone that works in either the NHS or private, the biggest thing you have to think about is a mentor. That is the hardest thing to get, and it's the thing that's going to bring you on more than others. I know other people on my courses, on the course that I was on, and I probably drop out because they got promised the world. There was one fella that was like he'd spoken to two radiologists in the NHS trust he worked at. They were like, yeah, no problem. And when it came to it, he just couldn't get the hours in with them because I don't know if any of you work with certain consultants that some time scales and time frames they're not maybe great with and time management. So they promised him the world. He says they would cancel clinics, stuff like that. Things would get moved. They get called into emergencies. He said he ended up having to pull out because he just couldn't get that side of things. Other people, they just find it's a lot harder to get it because it is quite expensive as well. Because again, the likes of me there, even for physio appointments, you're talking, we charge £60 for half an hour to see me for physio appointments. In my time is now worth 120 quid. So to take me out for a full day to watch someone else's scans, you're probably looking at somewhere between £600 to a grand, depending on where you want. So that is definitely something you'd want to think about because you will get charged when most people in private practice doing it because it's just time wise, it takes up a lot of our time to do it. And also, then if you're in the NHS side of things, you just want to make sure whoever you get to do it the time their time availability is realistic. So you just want to make sure that before you even I would say before you even think of starting a course, make sure you have that in place because that is by far the hardest thing.
Yeah. No, that's really helpful, and I think yeah, really helpful for everyone to hear as well, because there's a few questions about mentorship and supervision, which obviously seems to be quite a bit of a challenge really with people trying to get into this space. So
The other thing, just on that, I do know Smug. I know they because of the challenges they do something. I think now where they do it, you have to pay for it separately. And they weren't doing it when I was doing it with them, but I think they've done it the last year. Where if people are struggling to get their numbers in, that they basically get a load of patients into one of their places in London, and then we'll just get loads of students to come in and just scan different parts and scan different patients in one day, so that you can get your numbers up that way. Um, the issue I would say with that is that's great to get your numbers up, but if you can get in a place or have someone that you can constantly go back to for feedback, it will bring you on so much quicker. Because again, a colleague of mine, John, that works with me here, we both did it at the same time. He got someone that just basically signed off his scans and that was it. Where I was in a clinic where I got my scans signed off, but I still had that kind of person I could always jump in, double check with, and it brought me on way further, way quicker than and he would admit that himself. Than he got there eventually, but it just took him longer to get there. When you get that constant feedback, so
yeah.
being mindful of that as well. It's all well and good getting 250 scans supervised, but the rest of it is really important as well.
Yes, it's more like you're trying to get that mentorship opportunity, isn't it? And I know
Yes.
I say it's tricky to get some of those opportunities, but sort of like I say, just trying to reach out and find what works for you. Yeah, is definitely the way to go. We had a question about sort of how diagnostic ultrasound has changed your approach in clinic and whether you scan every patient. So yeah, how you've integrated that generally on a day-to-day into your MSK practice.
Yeah, so I don't scan every patient. I know that there's everyone has their own ways of doing it and models that they want. Again, obviously being in the private sector, I purposely made the choice to charge a bit higher to kind of make sure that it was only scanning people that was appropriate. I know there's other people that maybe just add on £20 to their prices and therefore then they just including that as part of that as a scan. The issue I was just wondering with that is then do I start getting things in the door that are just inappropriate a lot more because people go, oh, an 80 or 90 quid scan, I'll just go and get that scan and stuff. And I just felt like I don't want to scan everyone because you don't need to scan everyone. I only scan the people I feel like it's going to change my management. That's how I would use ultrasound for. So it's a case of when I'm thinking, right, this is either something to worry about, or if someone comes in and it looks like a patella tendon problem, it smells like one, looks like one, dances like one. I am not going to scan that person. I'm going to say because I do get people in that go, "Oh, do you think a scan's worth?" And I'll be like, "No, I don't think it's necessary in this case. It's only if we're then thinking, right, this is not improving how we want. We have the option to scan, and if we're thinking about going down injection things, or we think, right, let's scan to rule out anything else." Um, but having that and being upfront with people, especially in the private sector, works really well because then people appreciate that you're not taking the piss out of them, etc. Because will be places that be scan everything and then you end up getting a bad name for yourself. From that, so from a business point of view, that was very important. But also, the big thing it's changed for me is my anatomy understanding. It's made my anatomy go through the roof because we all know tendons, quadriceps, your quadriceps tendons, stuff like that. What we maybe don't understand, maybe as much in depth, especially I didn't until you did ultrasound, is things like how important the central tendon within the rec fem, how important that tendon is, and how you can often get tears of that, and how in particular that can cause these quad breakdowns that just seem to keep these football players that keep breaking down with quad issues. How the rec fem, and again, if we keep on that, has two different heads, and how part of the heads actually attach onto the joint capsule, and which is why we often get a lot of people that present with hip flexor problems, which I've realized now are way overdiagnosed. And a lot of times it's just being referred through the rec fem due to that. And again, ultrasounds open my eyes up to these kind of more intricate parts of anatomy that maybe I didn't understand, I didn't know as well before. Again, things like the arcata frouxe, which I've never heard of before. It's an area within between your two supinator heads, a fascial thing within your supinator heads, where your posterior interosseous nerve can often get entrapped. So again, ultrasound has opened my eyes up to a lot of these things and opened my eyes up to the anatomy variations, which then in turn has made my diagnostic skills go even better. So there's oftentimes I'll get people in and there's diagnostics or diagnoses that I wouldn't have given out in the past that I now am confident to give out. Maybe that I would think about more often because I've seen it more and more on ultrasound.
Yeah.
So it's definitely improved that side of things, which I think then in turn has helped patients because then I'm able to go, right, it's X, it's Y. When it's Y, let's just go down this route. With X, right, you need to get referred on, you need X, Y, Z instead.
Yeah, no, that's really good. And it's interesting to hear, like say, that confidence side from your diagnostic point of view, even away from using the ultrasound. Like say that's quite interesting. And like say the anatomy side, it's like learning anatomy again, isn't it? I'm sure. It's a completely different different aspect. So with that, then we had a question about any sort of challenges that practitioners face when integrating ultrasound. Have you faced anything with yourself and your own experience with the ultrasound, or would you say it is more like just the education side and sort of building up your confidence with it?
Yeah, if you're at the early stages and a starting point, the biggest challenge is getting a mentor and getting
Mhm.
again a mentor that, as I said, not only can sign off your scans, but someone that you can constantly go back to and get that feedback loop because that will just bring you on so much more. If you're looking from a business side of things, again, ultrasound does bring its own hassle. Don't get me wrong. I mean, John there recently had someone that came in with a knee problem, scanned, was coming in for an injection, scanned his knee, and John was like, "Whoa, this does not look how I was expecting it to look." And then I referred him urgently on for an MRI. Turned out, it was an osteosarcoma, basically a bone tumor in his knee, and sent him for a private MRI. That was, we got MRI the next day, got a confirmed bone tumor, then got that sorted, and your man ended up they ended up getting on top of it really quick. Oncology contacted us just to say that it was very impressive because they couldn't believe that he had managed to get both an ultrasound scan and an MRI done within 48 hours because they were like, the oncology team themselves even said, we couldn't get that done that quick, even urgently. So that helped that patient's kind of
Mm.
pathway and that. But that becomes a challenge. Again, this is where the issues come because once you stick that on someone, if you miss something, then
Mm.
you're hit for that. You know, I picked out again, and you often find them when you're not looking for them. Like that lady, obviously, I'm looking at that lump. I'm in my mind, well, this is a lump. Anything that looks dodgy, it's getting sent on. But then there's other cases where I've been scanning shoulders, for example, and then you come across lumps in the shoulder by accident. That you go, right, there's a big lump within the deltoid muscle that I wasn't expecting. Again, sometimes you can find these kind of intramuscular lipomas. And again, if you don't know that, you sometimes could scan over and half ignore it. But also, if you can't tell the difference and you think, oh, that's a lipoma and it's something nasty, that obviously opens you up to more liability. Whereas as a physio, without a scan, you can't. If someone has a lump there, you're never going to know that because you couldn't feel it. You know, it was integrated
Mm.
within the muscle. But that's where definitely you have to think about: is it worth all that kind of hassle? You know, especially if you don't feel you can get the right treatment. But
Mhm.
yeah, because that opens you up.
Yeah. No, of course, and I'm sure a lot of clinicians feel very similar. Just the last couple of questions, then. So we have a question surrounding optimization of image. So any advice on parameters? Obviously, this can be personalized generally to how you're looking at the image, I guess, as a clinician and sort of how your eyes work, etc. But has that been a process for you to optimize your own image as you've been going along with it, or?
Yeah, it's a hard one to answer because everyone's different. What
Yeah.
can I see even with me and John when I'm looking at stuff on when we do kind of like CPD sessions together and that. when I lay out, I'm like, oh, I can see that clear, but he's looking at it and he goes, I prefer when the
Mhm.
gain's up a little more, the gain's a bit down, or
Yeah.
again, changing the color scale. So rather than just your typical grays and whites, I can make it blue or red or yellow. And I can make everyone's different. So it's really hard to say image optimization. Angles are the biggest thing probably with that. I would say angles that you get at, it's really focusing again, like they teach you on all the courses, lighten up the bone. You light up the bone, it just makes every bit of tissue on top light up easier. And then there's nuances to that and things that you can change, but that happens as you get more experience. That's your simple and most bog standard thing to get good at. It's just getting control of the probe skills. Then all the fancy settings and that, your frequency, your gains, your dynamic range, and all that. You don't have to worry as much about them. Frequency, focus, and gain alone will be all you need to change in most cases once you've got the kind of bone bright, and then you can figure out what works for you.
Yeah, no, that's great. I think that's where we have quite a few questions surrounding this sometimes, asking for presets on the systems and so on. And like I say, sometimes it's a bit difficult because like I say, everyone is reading an image different, with their eyes and colour tones, etc. So good to hear from your point of view that like I say, experience and getting used to the machines and used to the image in front of you is where it's going to build and you're going to be able to work yourself with it. So great. Last question. I don't think there's anything else popped through. So last question is just about the feedback of patients and the impact that's had generally sort of in your clinic, the demand for patients with scanning. Obviously, you mentioned a little bit of, sometimes it's the patient asking you, is it worth a scan? And I'm guessing sometimes when patients do come through the door, they see the nice scanning machine and sort of want a bit of that, don't they? So has that been sort of something that you've experienced a bit with?
Again, this goes more into the business side of things because let's say
Yes.
you're in the NHS, of course, when it's not people aren't paying for it, who won't want a scan?
Yeah.
Who won't want a scan? That's the thing. Um, if I charge cheaper, could I get more people in for scans? Yeah, 100%. If I charge 20, 30 quid more, I'll probably my scan rate would go through the roof. But at the minute, I purposely have it because mm, again, I don't know how many people on this are working private sector versus the NHS. But anyone that's I've worked in both, like I have, will understand there's a definite difference between NHS and private patients. And the problem is that if you go too low in the private sector, you then get you're more likely to get your typical NHS type patient with way more comorbidities, way more problems. And this just opens up when you're scanned, this potentially opens up where you're going to kind of come across the nasties and stuff like that a bit more often than that. So I purposely actually charge a bit higher to kind of try to limit the amount of scanning we do, and just to try and keep it contained to those that definitely need it. But that's my choice. Other places will go like, oh, we'll include privately would include a scan at the same price with every physio consultation, and you'll be rammed. People want scans, absolutely rammed out the door. But then you get way more hassle, way more paperwork, way more admin time. Everyone wants a copy of their scan results, and even 6 months down the line, people are emailing you asking for it. So then you start to go, right, I'm not maybe making for what I'm charging with all the extra hassle. Am I really making that much more money for all the hassle for that? I don't know. Plus, then you're using the machine more likely to drop it, more likely to get problems. Then probes, as Katie will tell you, ain't bloody cheap to replace. So that's that side of it. But again, if you're in the NHS and doing it, yeah,
Definitely.
everyone does. There is a demand.
Yeah. Okay. No, great. That's really really useful. And yeah, thank you for those cases. Really interesting for people to sort of have an insight to sort of just day-to-day clinic really with using diagnostic ultrasounds have been really helpful. So after this after the session, I'll send out the recording as well as a survey. So any feedback will be much appreciated. Shane, you frequently share obviously bits of snippets on socials
Yeah.
of the scans and sort of your insights and etc. So I will also link your Instagram, but otherwise it's motherwell_physio, so you can check out the bits on there.
What what I would also say, because I get at least 1 to 2 people a week message me about this. So I'll just say to anyone, like, look, if you want to ask a bit more in-depth questions to me about ultrasound, that just feel free to contact me on the Instagram. Just drop me a
Mhm.
message, and I'll just answer everything back. I get them at least 1 or 2 times a week from clinics and clinicians from up the UK. So feel free just to message me, and I will get back to you.
Oh, that's great. That's great. Perfect. So yeah, we'll end it there. Thank you so much again, Shane, for taking the time. We'll leave you to your busy clinic. Maybe have some lunch if you've not had it already. But yeah, thank you so much again. And yeah, everyone enjoy the rest of the day.
Right. Take care.
Bye.